Okay, so it's a good thing I paused it right there because, well, when I was looking to press stop, I almost drove off the road, and my dog just made some funky noise, like he's about to throw up. He's probably gonna come over here and sit with me. He doesn't like sitting over there by himself. Come on. Yeah, all right, baby. Okay, so we talked about the monoclonal antibodies. We talked about that one somatostatin receptor. And I would like to point out, you really should go back and review Trio Scan and MIBG, because it's oncology and it's fair game. You might see a question on the test. Remember, you cannot compartmentalize. Information you learned last semester is still fair game this semester. You can't let it go out of your head. You got to remember it. So that's my warning to you. You might see a question or two about Trio Scan or MIBG. Also, I'm not going to talk about it on this video because we talked about it last semester, but the thyroid imaging and thyroid cancer treatment. That is in the PowerPoint. I think it's a pretty good review of what we covered last semester. Again, it's fair game for the exam. So make sure you know thyroid cancer treatment, and thyroid metastatic survey. Okay? All right. Let's talk about lymphoscintigraphy and breast imaging. I'm actually really excited about this. Okay, so lymphoscintigraphy, what was really exciting is we were supposed to have a lab on this, and we were going to practice injecting stuff, not on each other, but we were going to practice sub or intradermal injections. I will try to find a YouTube video to upload to go along with that, since you won't get to practice it. It's not at the end of the world if you don't practice it. So with intradermal injections, it's site specific. So some clinical sites, the technologist does the intradermal injections for lymphoscintigraphy. At some clinical sites, the radiologist or a physician assistant does the injections. Every clinical facility that I have ever worked in, rotated through as a student, anything like that, has always been the radiologist. I have never done intradermal injections as a technologist. Okay? And I don't think that any of our clinical affiliates that you'll rotate through, I don't think the technologists do the intradermal injection. I'm pretty sure it's a physician assistant or the radiologist. Okay? So, but it's still good to know, because you might get a job where you have to do it. Okay. So lymphoscintigraphy. All right. So this is not directly. We're not directly imaging cancer like we are with the other procedures in this chapter, okay, or in this module. But it is a very, very important tool in the management of cancer. All right. So I mentioned it a little bit before. Cancer, and it's in some cancers are more prone to do this than others, but some cancers are really good at finding their way into the lymphatic system. And it's not necessarily that they invade the lymphatic system, it's that it's really the body trying to do its job. These cancer cells work their way out of their tumor, get into the bloodstream, and then they get filtered out of the bloodstream into the lymphatic system, and then they get trapped in lymph nodes. And that's what the lymph nodes are there for. The lymphatic system is designed exactly to do this. When stuff gets in the bloodstream, the lymphatic system's job is suck it out and attack it and eat it before it causes damage. Unfortunately, with the cancer cells, the lymphatic system usually can't handle it. So what happens is the cancer cells, they get into the lymphatic system, they implant in the lymph nodes, and they start to grow. So now the lymph node becomes a cancerous site. And then when that happens, these cancer cells now have free reign to travel throughout the body using the lymphatic system. So then they get implanted into the spleen, they make it into the bone, and cause bone metastasis. They work their way into the liver, into the lungs, because the lymphatic system is connected to all of this via the circulatory system. So with breast cancer and melanoma, with those two cancers, they are, I'm sorry, I'm hitting a lot of bumps. I'm sorry for my phone. The video's bouncing all around. I apologize. Virginia roads, damn it. Okay, so anyway, so with breast cancer and melanoma, especially melanoma, those are cancers that very, very easily spread via the lymphatic system. So when a patient has been diagnosed with either of these, usually it's a no-brainer. There's going to be surgery involved. It's either surgery to excise or remove the melanoma, or surgery to remove the tumor within the breast, or they may actually just take the whole breast. So if they're removing just the tumor from the breast, it's called a lumpectomy. Ectomy being surgical removal of, and lump is a lump. Lumpectomy, real technical term. And then the medical term for removal of the whole breast is mastectomy. 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 So part of this treatment plan or treatment strategy is to test the lymph nodes that are near the tumor, to see if there are any cancer cells there. All right, because if they're there, we might as well get them out. We're in this OR, we have the patient asleep, we're already taking something out. We might as well test these lymph nodes, and if they're cancerous or have any cancer cells, get them out before those cancer cells move to the next lymph node and then end up in the bone or whatever. So what could happen is patient goes into surgery. Let's talk about breast first. Patient goes in, they're having their left breast worked on. There's a lump in the breast. We're going to remove that lump in the left breast, and we're going to take out lymph nodes. Okay? So without nuclear medicine, without any means to identify lymph nodes, they would basically have to just go into the axilla, which is the armpit. The axilla is the part, would be the part of the lymphatic system that would drain the breast. Go in here surgically and grab every lymph node that we can find. Just take them all out, okay? And then once we get them out, we can biopsy them and see if there's any cancer, and probably what we'd find out is, maybe one or two had cancer, possibly, but we'd probably find that we took out a lot of lymph nodes that had no cancer in them at all, and they could have stayed in the patient. The more lymph nodes we remove, the more problems we potentially create for the patient. So without the lymph nodes don't regenerate. So if we remove these lymph nodes, now we have a part of the body, the arm, the breast, that is going to be very susceptible to infections. We don't have the defense built in anymore because we've taken them out. We've taken the lymph nodes out. So if the patient has any type of, exposure to an infectious process in this arm and this breast, the patient's almost defenseless. And there's a good chance the patient's going to get sick, and they may even die from the infection. So we saved them from the cancer, but now we've doomed them from a simple infection. So, what we want to do is we want to remove as few lymph nodes as possible. So the lymphatic system, the way it drains, it is a complicated network, but it's not like a mesh. So the lymphatics that drain a specific part of the breast are going to follow a very specific path, and they're going to hit lymph nodes in a specific order. They're going to hit this lymph node first, and then they'll go to the next lymph node, then the next lymph node. Okay? So that very first lymph node, so if we're talking about a lump in the breast, the very first lymph node that drains that area where the tumor is, that lymph node, if cancer is spread, that lymph node is probably going to have the cancer in it, okay? And that node, that first node, is known as the sentinel node, okay? Sentinel lymph node. Our job in nuclear medicine is to help the surgeon locate the sentinel lymph node, okay? So that they can take it out and biopsy it. So they have the patient there in surgery. Now they're not taking out dozens of lymph nodes and biopsying them. They're going to take out one that was identified through nuclear medicine. Excuse me. The pathologist will be right there, do a quick test. Yes, there's cancer. Okay, so then the physician goes, all right, let's go to the next lymph node. Take it out. Biopsy it. Nope, there's no cancer. All right, good. So it looks like the cancer only spread to one lymph node, so that's where we can stop. If that second lymph node shows cancer cells, and they just keep going. They keep going to the next lymph node, until they get a lymph node that doesn't have any cancer cells. But because of nuclear medicine techniques, they identify that pathway, and they know which lymph nodes to resect or excise. All right, so it's a lot quicker recovery for the patient. It's not all this mangling surgery in their armpit, harvesting tons of lymph nodes. And we reduce the side effects, the possibility of infections later on by leaving a vast majority of those lymph nodes in the axilla. All right, so how do we go about doing this? So the lymph nodes, their job is to filter out particulate matter that gets into the interstitial space. So the lymph doesn't filter the blood. That's the spleen and the liver's job. But we know that blood plasma, permeates through capillaries. It ends up in the tissue space, the interstitial space, and we end up with this fluid. And when it returns, it can either return to the circulatory system or it returns to the lymphatic system as lymph. Okay, so if we can place something that is particulate in nature into the interstitial space, we can, see the lymphatic system. The lymphatic system will filter that out, and it'll start to track through the lymphatics, and it'll go to the lymph nodes. So what we use is technetium sulfur colloid. Okay, that's the most common one. So sulfur colloid, it's colloidal, it's particulate. It's injected intradermally, so within the skin. And then when we do that, the lymphatic system starts doing its work. It starts trying to filter it out. Some of it does end up in the bloodstream. So with that, we might see a little bit of liver activity. We might see a little bit of spleen activity because some of the sulfur colloid does make it into the circulatory system and get filtered out by those methods, right? But the vast majority of it ends up in the lymphatic system. So we inject it, and if we put the patient under the camera, we can actually see the lymphatic vessels, and we can see the lymph nodes, and we can identify the sentinel lymph node for the physician. There is a second radiopharmaceutical. It's a relatively new radiopharmaceutical, technecium tilmanocept. The brand name is Lymphoseek. It is not a particulate, okay? It's not colloidal. It actually binds to lymphocytes and gets incorporated into the lymphatic or the lymph nodes and the cells of the lymph nodes differently. So it's not a filtering process like sulfur colloid. It's actually a chemical process, okay? But it still gives us the same results for the most part. Okay, so with lymphoscintigraphy, and the concept here is the exact same for melanoma. All right, melanoma is highly invasive of the skin, and because it's buried in the skin, the lymphatic system is very susceptible to those cancer cells. So the same thing, if we can instill sulfur colloid or tilmanocept around the area of the melanoma, there's a good chance we can map out the lymphatic system in that area. All right. So the procedure is we inject. It depends on the facility. Some facilities do 2 injections around the tumor site. There's a lot of variability. Some places do 4 injections. Some places do 6 injections. If we're talking about melanoma, 99% of the time, the injections are around the melanoma site. So if I had a melanoma on my cheek, it would be 1 injection, 2, 3, 4. So 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock around the melanoma, okay? So we're gonna get the lymphatic drainage from all directions. If we're talking about breast cancer, there's a couple of variations. Some facilities will actually find the lump in the breast and inject around that lump, and it might be 2 injections. At some places do 12 and 3, some places do 12 and 6. Some places do 4 injections, same thing, 12, 3, 6, 9 o'clock. Some places do it around the nipple, and that's mostly what I've seen, because we're really looking at the breast tumor. The cancerous tumor is inside the breast. It's not on the surface. It's palpable at the surface. You can feel it, but it's really buried deep into the breast tissue. So you're not really you may be injecting around the palpable area, but you're not injecting around the tumor like you are with melanoma. So most places inject around the nipple, and then that really catches the lymphatic system for the entire breast. All right, because the tumor is going to follow that same path, that same lymphatic pathway. The dosage, it's usually 100 microcuries per injection. So the total dose is usually like around 400 to 600 microcuries. So it might be, 200 microcuries, 200 microcuries. It might be 100 microcuries, 100 microcuries, 100 microcuries, 100 microcuries. It just kind of depends. Some places will do 2 injections for breast. That's what I'm used to. 2 injections for breast, 4 injections for melanoma. It's site specific. So the injections, they're really right up under the skin. So when the pharmaceutical goes in, it looks like almost like a bee sting or a mosquito bite. The skin whelps up from the liquid, and because with sulfur colloid, because it is particulate, it can be quite painful. Especially, some parts of if we're talking about a melanoma, if it's a melanoma on your arm, yeah, it's going to sting really bad, but, that's not going to hurt as bad, probably, as 4 injections around your nipple, okay? Around the areola. That's going to be quite painful. So, be prepared when you see these. Now, with Lymphoseek's big selling point is that it is many, many times less painful than sulfur colloid because it's not particulate. So there is a little bit of discomfort there when the injection is made, but it's not. It's usually not the same pain. I've worked with both, and I have had patients when we inject the sulfur colloid, they almost come off the table because it hurts so bad. I've had patients cry. I've had patients say, "Oh, that's not so bad," with sulfur colloid. With tilmanocept, I've had patients come off the table. I've had patients cry, and I've had patients say that wasn't so bad. So it seems that, with sulfur colloid, there were definitely more patients who experienced a higher level of pain than the patients patients with tilmanocept. So with tilmanocept, I had more patients say, "Oh, that wasn't so bad," than I did with sulfur colloid. But with the injection technique is very, very, very important. If the injection is made too deep below the skin, so subdermal, not intradermal, if it's made below the layers of the skin, it gets into the circulatory system and usually not into the lymphatic system. And that is very, very true, very, very true of sulfur colloid. With tilmanocept, another selling point with tilmanocept is that it's less, the outcomes of the procedure, the quality of the procedure is less dependent on injection technique. So if you inject too deep with tilmanocept, there's still a good chance that you're going to be able to find a sentinel lymph node. Sulfur colloid injection technique is very, very critical. So usually what I found with sulfur colloid is it should hurt. That's just the bottom line. It should hurt. If the patient says, if you do an injection, the patient says, oh, that wasn't so bad. They don't grimace, they don't go, oh my God. If they don't feel pain, then you're probably too deep. If you don't see the skin well up when you're injecting the sulfur colloid, you're too deep. It should well up. It is just under the top layer of the skin. So it's in the dermis. And that's very important. If you go too deep, it doesn't get into the lymphatic system and you won't find your sentinel lymph node. God, there's a lot to talk about with this. Okay, so these procedures are 9 times out of 10, they're done just prior to the patient going to surgery. So some facilities will do the injection of the radiotracer, whether it's breast or melanoma, and they will do imaging. They'll put the patient under the camera and they will map out the lymphatic system. And they will identify the sentinel lymph node on the images, and then they will mark on the skin where that sentinel lymph node is. All right? That's really hard to describe over video. It's something you really need to see. For like melanomas, a lot of time, it just kind of depends. For melanomas, a lot of times, you can identify the sentinel lymph node on the surface of the skin with one mark. When you get into the axilla, you sometimes have to put 2 marks. You have to put an anterior mark and a lateral mark. And then the idea is, okay, so I've marked here, and I've marked here. I'm trying to do this with my hands on the steering wheel. Okay, I marked here. So the idea is that the lymph node exists somewhere in between there, because I'm marking it using a 2-dimensional image within a 3-dimensional patient object. So sometimes you kind of triangulate it. You mark here on the skin, and the surgeon knows it's somewhere in between the two, inside the patient's body. But that you really kind of have to see in practice. Some facilities, and what I was really used to is with breast imaging, with breast lymphoscintigraphy, we only did injections. We didn't do imaging. So the way the surgeon found the lymph node was through the use of that neoprobe. We talked about it in instrumentation. So it's the little probe with the little radiation detector on the end, and the closer and closer, he tracks it. He finds the injection site, and then he tracks it, and the count rate goes up the closer he gets to a sentinel lymph node. And so that's how he finds it. With melanomas, we always did imaging. The surgeon still uses the neoprobe, but we always did imaging, and we always marked it. The surgeon would come over to nuclear medicine and look at the images usually, and we would say, okay, this is where, this is the lymph node, so I did a mark here and here to help you triangulate it, for example. And then breast was just the injections. We didn't do any imaging. I'm trying to think what else. Also with lymphoscintigraphy, so when you're doing the imaging, you put the patient under the camera, and really all you see are these hot spots. You see the injection site as a very, very hot spot on your image. And then you might see the lymphatic vessels. You may not see the lymphatic vessels. But then, the next thing that you see are the lymph nodes. So usually the way it would work is the patient gets the injections on the imaging table. You immediately slide them under the camera and you start imaging. Some facilities will do dynamic imaging, so 1 minute per frame for 30 frames. So they'll do 30 minutes of imaging and they'll watch it move. Other facilities will do static images. So do the injection, slide the patient under the camera, and do a 2-minute static. Slide them out of the camera, wait 5 or 10 minutes, put them back under, do another 2-minute static. And you just keep doing these static images until you identify the lymph node, all right? So again, on these images, really all you see are these hot spots. You don't really see anything else because, especially if it's a good injection, there's no blood pool activity. There's only the activity in the lymphatic system. So it's kind of hard looking at the images when all you see are 2 or 3 hot spots and you don't see any other anatomical markers. It's hard to identify where these hot spots are within the patient. So a lot of times what the technologist will do is what's called a transmission image. And we will take that cobalt sheet source that we use for daily extrinsic floods. And while we're acquiring an image on the patient, we'll hold the extrinsic flood on one side of the patient. So I know it's kind of hard to say. So the flood sheet source is here. We're imaging my head, and here's the camera. So what happens is cobalt has a fairly low energy, and it's a low activity. So a lot of the photons get attenuated by my head. So what we see on the image is we see the outline of my skull on this transmission image. So it helps us localize the sentinel node better within the body when we have this outline of the patient's body. And that's called a transmission image. So a lot of times because we end up marking lymph nodes, in 2 planes, anterior and laterally, a lot of times, maybe posterior and laterally, so that the physician can triangulate where the lymph node is within the body. A lot of times when we image anterior and laterally. So our camera is in the 90 degree orientation, the camera heads. So at one time we're acquiring an anterior and we're acquiring a right lateral, for example. So when we do our transmission image, let's say our images are 5 minutes apiece, the acquisition is. So you'll start the acquisition, and as the technologist for 2 minutes, you'll stand there with the cobalt sheet source on the lateral aspect of the patient. So you're getting a lateral transmission image. And then for the last 2 minutes of the image, you move the transmission source, the cobalt sheet source, behind the patient's head. So now you're getting an anterior transmission source. So you hold the source there for a couple of minutes so that there's enough counts to get that shadow, to get that silhouette. So that's a transmission image. For breast imaging, for breast lymphoscintigraphy, if you're not going to do imaging, a lot of times these injections are done over in the pre-surgery area. So when patients check in for surgery, a lot of these are day surgery, so outpatient surgery a lot of times. Patient checks in for surgery, they go to like a little holding bay, and that's where they sit until they actually go into the OR. So it's in that room a lot of times where we do the lymphoscintigraphy injections. And then the patient goes to the OR. And then obviously with a melanoma, where we're actually mapping out lymph nodes, that's done in the nuclear medicine department, but it's still done, an hour or so before surgery. And generally patients, the goal was to get patients injected. If we were doing the breast thing over in the surgery area, so we weren't doing imaging, the goal was to have the patient injected at least 1 hour prior to surgery. That gave the sulfur colloid time to move into the lymphatic system and get into the lymph nodes. And what you'll find is, based on injection technique and based on each patient, just them being individuals, you'll see that some lymph nodes, if you're doing imaging, show up really quickly. Like you do the injection, and by the time you get the patient under the camera to start your first image, you already see a lymph node. Some patients you will image for an hour before you see a lymph node. Sometimes you will image a patient and surgery will call and say, we've got to have this patient over the OR, and you're saying, I still don't see a lymph node. Oh well, then we just don't have a lymph node and they got to go to surgery because we can't back up the OR. So every patient is different. Obviously we like it when they show up quickly, but because everybody is different, for breasts, we don't, if you're not doing the imaging, you don't have the luxury of confirming that a lymph node really did take up the radiopharmaceutical. So you want to inject as early as possible. Once it gets into the lymph node, it pretty much is locked in. We would even do, for patients who are having very, very early morning surgeries, like they were the first person in the OR at 7 a.m., we would even have those patients come in the afternoon before their surgery, do the injection, and then the next morning they go for surgery, and the physician can still localize the sentinel lymph node, even though it had been 18 hours. And usually in that case we up the dose. We usually did I believe it was 500 microcuries per injection for those, just to account for the decay overnight before the patient returned for surgery the next day. Those were pretty rare, but we did do them. What else? Okay, so most facilities, this is one unique feature of lymphoscintigraphy is it is considered, for many facilities, they consider it an invasive procedure because it's not that the lymphoscintigraphy itself is invasive, but it's a part of an invasive procedure. It's a part of a surgical procedure. So with any type of surgical procedure, whether it's in the OR, having a lump removed from the breast, toe amputated, gallbladder removed, or if it's a procedure in CT, a biopsy. Each hospital defines what they call invasive procedures. With invasive procedures, surgical procedures, there has to be what's called a timeout. If any of you have ever had surgery, you've probably experienced the timeout. The timeout is where everybody, and it usually includes the patient, everybody who's involved in a procedure stops what they're doing, all tasks cease, everybody listens, and we review the patient. We make sure that we have the correct patient, so the patient states their name and date of birth while somebody checks against the armband, and while somebody checks against the consent for the procedure and the order for the procedure. So we want to make sure that the order, the consent, and the armband match what the person in front of us is telling us who they are. And then we confirm the procedure. And a lot of times there's laterality involved. So an example would be, if I were doing, let's say I'm doing a lymphoscintigraphy on my dog right here, on his left front paw. So I would say, all right, everybody in the room, we're going to stop and do a timeout. This is Hamilton Robinson, date of birth August 18th, 2004. He is here today, and we are doing a melanoma excision on the left front paw. Does everybody agree with that? And everybody has to agree, including the patient if they're awake. And there are usually several timeouts because people change, people come in and out. We are involved in a certain portion of the procedure, but we're not involved in the surgery itself. So we will have a timeout before we do our injections. And then they will do another timeout in the OR, probably once the patient is asleep, before they actually do the first cut on the patient. So So the timeout is a very, very important, process when a surgery is being performed. Because the last thing we want to do is operate on the wrong side, the wrong site, the wrong patient. Have a patient in here that's supposed to be getting their gallbladder removed, and we end up removing the right breast. Oh my God. Terrible, terrible. So that's why the timeout is so important. And a lot of times, lymphoscintigraphies are a timeout procedure. So be prepared for that. And a lot of times, I'm going to tell you. It usually falls on the technologist or the nurse to initiate a timeout. It is exceedingly rare, in my experience, for the radiologist or a physician to initiate a timeout. They will just come in, pick up the syringe, and they start injecting. Because that is when you got to just say, wait, we need to do a timeout. This is who we have here. I confirm that that all of this makes sense to me. You need to confirm that before you start sticking needles in people's body. The procedure itself isn't that much different than what we do. When we start IVs all the time, we do injections, we do images. None of that's out of the ordinary. But because it's related to a surgical procedure, we usually have to do the timeout. So I wanted to point that out. Okay, I need another sip of this one too. I don't know that there's anything else I need to say about lymphoscintigraphies. I just realized I have not used my cruise control this whole time, and I'm going like 80 miles an hour. So let's go ahead and set this cruise control before I get a speeding ticket. Alright, there we go. Change lanes. Check my blind spot. I'm a good driver. Okay, so now let's talk about breast imaging. Okay, so breast imaging, not to be confused with lymphoscintigraphy for breast cancer. Breast imaging is actually imaging for the cancer. Before we were talking about finding the lymph nodes, not the cancer. We weren't really, cancer was a part of it, but that's not what we were looking for. We were just trying to find the central lymph node. And then they figure out if there's cancer in there. Okay, so now with breast imaging, we are actually looking for cancer. So, mammograms are the gold standard. Mammograms are the mainstay of diagnosing breast cancer. Okay, women have screening mammograms every year. They should be on a regular schedule, starting at a certain age. And mammography is a very, very, very powerful tool, and it's a very effective tool. All right. The problem with mammography, with mammo, we're looking at X-rays, all right, and we're looking at densities in the breast. So we're relying on the attenuation of X-rays as they pass through the breast to identify these areas of hyperdensity, which could signify cancer. Mammos don't diagnose cancer, they just detect lesions. The next step, you guessed it, biopsy. We have to stick a needle in there, and we have to sample these cells. Because there's a lot of breast cysts that are not cancerous. They're not anything we need to worry about. So mammography really doesn't differentiate a benign cyst from a malignant tumor, okay? It can to some degree, but anyway. So, breast density, that's what we're looking at. We're looking at the attenuation coefficients because of the densities in the breast. So if you have a patient who has large, dense breasts, the sensitivity for detecting cysts and tumors from mammography is compromised. So that's where breast-specific nuclear medicine imaging comes in. And I'm trying to be very, very careful with my terminology. So breast imaging in nuclear medicine falls into two categories. There's breast-specific gamma imaging, BSGI. breast-specific gamma imaging. Then there is molecular breast imaging. I just want to make sure I'm saying that right, because again, I don't have my notes. All right. So, both procedures use technetium sestamibi. All right. So yes, that is the radiopharmaceutical we use for the heart. It was, discovered when sestamibi was first being, tested and used for cardiac imaging. It was identified that sestamibi concentrates in breast cancer. So it is a fairly sensitive tool for detecting breast cancer. Not super specific, because it can accumulate in some other stuff, but the sensitivity of detecting breast cancer in dense breasts is higher than the sensitivity of detecting breast cancer with mammography. All right, so breast-specific gamma imaging and molecular breast imaging both use sestamibi or tetraplasmin. Tetraplasmin is very similar. With breast-specific gamma imaging, we're using a nuclear medicine camera, like what we've learned about. It's got a crystal, it's got photomultiplier tubes, it's got a collimator. We may actually use a standard gamma camera that we would use to do HIDA scans and cardiac SPECT and bone scans, just a normal nuclear scanner. We may use a gamma camera that is built specifically to image the breasts. So the way the camera face is oriented, it's even got a compression plate so that the breast can be compressed, between either two detectors or between a detector and a plate. But it's the normal nuclear medicine. It's a normal instrumentation for a nuclear medicine camera. With molecular breast imaging, we are using a specialized camera that is specific to breast imaging, and it does not use a crystal with photomultiplier tubes. It uses CZT semiconductors as detectors. So similar to what we have in the nuclear medicine lab. So with that, the sensitivity goes up even higher because the resolution on that type of camera is much better than the resolution on a standard gamma camera. All right. So really, that's the two differences. I'm not going to get too much into it because I've been talking and talking and talking. My voice is getting sore. I've been talking for almost 2 hours, but I uploaded several articles in Blackboard that are related to breast-specific gamma imaging and molecular breast imaging. So please take the time to read those and read, more in more detail why these procedures are, better than mammo for these dense breasts. All right, so I think I'm done. I think I've covered oncology as much as I can, as much as you probably want to listen to. If you have any questions, reach out to me. Please email me. You can send me a little message on the group chat that you have emailed me. I should be available this weekend, even though I'm going to be in Georgia. I'll still have my phone. So it should be impossible to get a hold of me at some point if you needed to. It might take me a little while to respond, but I am around. So anyway, and you're probably watching this video after the weekend's over. So I don't even know when this is going to get posted. So anyway, y'all have a wonderful Easter, or I hope you had a wonderful Easter, because I don't